Our last speaker of the session is going to talk on a similar kind of theme. And, just to kind of echo how important this question is to the field right now, there are multiple groups sort of working on how you address nutrition in TB. I'm very happy to introduce Sandeep Mandal from the John Snow Institute in India, who will also be talking about modeling nutritional interventions for TB. Sandeep, go ahead.
Good morning, everyone. This will be, I'll be talking also the similar what Rebecca just presented, but in the population level in Southeast Asian region countries. We studied the similar kind of mathematical analysis based on that Bhargava study on ration trial. So the outline of my talk is something like that, the gist of ration trial I will show means what we get from there, from those studies. And then I will briefly describe how our model works. We developed some mathematical model, transmission model, and how it works, how it fits in the model. I'll show details. And then I'll show the findings and I will summarize the things. So this is already published work. So already my previous speaker already mentioned about these two papers, nutritional ration trial, what suggests that it could reduce incidence by around 40 to 50% among household contacts, and simultaneously it can reduce hazard of death around 39% if with a 5% weight gain in 2 months. These are the main two information which is used for our modeling purpose. So the study, the ration trial, was done in a single state in India, in Jharkhand. And if you look up at the state, that undernutritional status is not comparable to India, actually. If you want to compare that result and you apply to across India, that is not the fact. Actually, undernutritional status is lower than the national average of India in Jharkhand. But anyway, we don't have any other options. The information we get, we just apply the similar information to the country, across the country, as well as the region, Southeast Asia regional country, 11 countries. We did this. These are limitation, you can say. So the underweight among adults, prevalence of underweight among adults, we got the data from Global Health Observatory. The data, we use this, but we have some doubts though. Say for DPR Korea, it suggests that 6.6% is low BMI. I don't know whether these are how believable, but we use these data sets for to model, to get the impact of nutritional support for all these 11 countries. India, where it shows that 23.6% BMI, low BMI, less than 18.5. Now let me describe the model. This is transmission model, like differential equation-based model, as we usually use for transmission dynamics, to capture the transmission dynamics, to capture the natural history of TB dynamics. Here we have uninfected population. These compartments represents the different, those are not familiar with model. For them, actually, specifically, I'm speaking this. So we divide the population into some compartment. Those are not infected, are kept in the same box, say uninfected U. And then latent fast, latent compartment is divided into two, latent fast and latent slow. Then they develop active disease. Once they develop active disease, they have choice, either they seek care for diagnosis and treatment in public sector or in private sector, either NTB sector or in non-NTB sector. So it branches this way. Those goes to the NTB sector, can be treated in the same sector, or if it misdiagnosed, it could come some other, in another box here, that E, misdiagnosed and temporarily disengaged. So they can again come back to some sector to get it diagnosed and finally get treatment. So So once they are on treatment, depending on their treatment outcome, they could be cured with deferred rate, or they could be in default, or all these processes could be done, would be here with the defined relapse risk. They will have relapse probability of relapse. And for simplicity, we have not shown here in the structure. We have not shown the the model considered reinfection, model considered self-cure. All these things are not shown in this diagram to keep it clear. But the most important part for this model is that this structure, this general structure is divided into 3 layers. First one is with normal BMI. If people are in normal BMI, they will follow this structure. People with low BMI, they also follow this structure. And there is another layer which low BMI but with nutritional support. Then what are the difference between these 2 categories? There are 3 layers with normal BMI, low BMI, and low BMI with nutritional support. Now the main difference comes here in the structure, means uninfected to latent and then developing active disease. What are the differences? Let's show here. In the normal BMI population, say the left hand side, this shows that structure for normal BMI, uninfected, latent, slow, latent fast, latent slow, and then active disease. Here the right hand side, it shows the low BMI population. And the difference in normal BMI and low BMI, main difference is that relative risk of TB among undernourished population is 3.2 times, means around 3 times higher than normal BMI. We calibrated our model to fit this, means if the relative risk of 3.2 times higher in low BMI, so what is the difference between normal BMI and low BMI? Here the main difference is the activation rate and progression rate that should be higher in the low BMI setting. Here, say here L0 to this is U, and if from L0 from slow progression, this is W. But here it is considered that it is K times higher than the normal BMI population. Also, you should remember that relapse risk is much higher in the low BMI population, around 4 times higher than the low BMI population, than the normal BMI population. Now we calibrated our model in such a way that to capture this, means what is we estimate the value of K. What value of K will give me this information that relative risk could be 3.2 times higher than the normal BMI. This way model has been calibrated. And now for that was the first step of model calibration. And the next step, what we did is that we introduced another compartment, because those are getting nutritional support. Similar structure, but those are getting nutritional support with different categories. Here the difference, again, the difference would be if we give nutritional support, their progression rate and activation rate would be reduced. Say here it is K, and now we introduce it as K prime. So we tried to feed the relative variation of K and K prime with the nutritional support. And what is that? That has been modeled through that Bhargava study, that trial study. So that incidence reduction would be 40% in this group, in the middle group, than the left-hand group. So all models have, lots of assumptions. So this model also have some assumptions, like before intervention, we assume that among TBI, progression and reactivation rate is higher amongst low BMI than normal BMI. Already I described in the figure. Similarly, relapse rate is 4 times higher among low BMI relative to normal BMI. Untreated TB mortality hazard in low BMI is twice as high as normal BMI. Again, case fatality rate, which is also higher in low BMI, is at low BMI 6%, whereas in normal BMI it is around 4% from India study. And we ignored any nutritional shocks related to COVID-19 pandemic. Now, these are before intervention. What happens with intervention? With intervention means with nutritional intervention. The first assumptions with nutritional intervention that it will reduce the cumulative incidence by 40% by lowering progression and reactivation rate. Similarly, a relapse rate which is 4 times higher among low BMI. These is completely assumptions. It will restore the relapse hazard to the same level as normal BMI. Similarly, for mortality hazard, we assume that if we give the nutritional support, that would be at the same level as normal BMI. Case fatality rate during treatment to same level as normal BMI. These are the assumptions for interventions. From the observations, from the recent trial observation is only from that 40% lowering down of incidence, or that means which is progression rate and reduction rate is reduced by 40%. Now, here through this model, we studied 2 scenarios. One, if we give nutritional intervention to all index cases, regardless of nutrition, all contacts of index cases, regardless of nutritional status, which actually is done in the recent trial. And in an alternative scenario, what we developed is that even not thinking about that household contacts, but give 30%, if we can cover 30% of the undernourished people each year, then what could be the impact of nutritional status in India as well as for other countries. So that means the intervention is already I described in the model, but here I'm repeating the same thing, that this is done by shifting individuals from low BMI to low BMI with nutritional support. That means from left-hand column of my model structure that I showed to the middle column. So low BMI with nutritional status. Intervention is scaled up, means 30% coverage means not in, at the beginning, just we started in 2023 and it's scaled up till 2025 to reach the 30% coverage, and it would continue. This way the model is scaled up. And this is also an assumption that though the recent study is done only on household contacts, but this is this model, when we studied this work, we applied this to even to 30% low BMI populations in general population, not only the household contacts. So now see the impact of intervention by covering. I am showing only an illustrative example for the 30% coverage of nutritional support. Here, left-hand side shows that this in the region WHO-CR zone, the result. The baseline, the red line here is the baseline without any intervention and without any disruption, COVID disruption also. So now with COVID disruption, the baseline shifted to this blue line above. And now, after that, we are looking at the different interventions like nutritional support of 30%. Now, left-hand side shows that for status quo comparator, means without any other interventions, only we are focusing only the nutritional support. Then, what could be the impact of that support, 30% nutritional support? So this one shows that one. And the bottom figure shows the annual mortality per 100,000 population. The color coding is the same for bottom and top. And the right hand side, you see this one is the similar baseline, and the blue line is the with disruption scenario, and then the green one is the with other interventions, with the interventions currently continuing, that active case finding or all other different interventions which is going on. And upon that, if we apply nutritional support, what could be the possible impact is shown there in incidence and as well as in the mortality. So in terms of result, we can say that it varies from country to country, impact varies from country to country. Here in the status quo comparator for Bhutan, where the impact was less, incidence means incremental reduction of incidence in 2030 related to 2015 was 6% for incidence and mortality 14%, whereas with improved cascade comparator, it is 3% to 5%, it got reduced slightly. Similarly, for India, the impact is slightly higher, means higher than the Bhutan. It is 24% reduction in incidence, whereas 35% in mortality. This incremental reduction. And improved cascade scenario gives 13 and 70% respectively. Now, this figure actually shows that how the impact of this intervention on if we target only the household contacts. The percentage case averted during this period is you can just for comparison, we put all the country result, how it happens without nutritional interventions, with the existing interventions. Improved cascade includes PPM, private public mixing, improved diagnostic outcomes in routine programmatic setting, case finding efforts, etc. So this is the impact. Now, with this, if we add nutritional intervention, that red color bar is showing the impact of additional intervention due to nutritional effect to the household context. Now, see the result. If we apply this thing for the 30% low BMI nutritional, 30% of the low BMI population, the impact would be obviously relatively much higher than if we target only the household contacts. So again, it varies from country to country depending on their current nutritional status. Means what proportion of population are at low BMI at this stage. Depending on that, it could vary from country to country. And by the bottom one, it shows the deaths averted, and top is the number of cases averted. So these are the main results. Now, as I said, that model has limitation. We have not considered the age structure in this analysis. We didn't distinguish about pulmonary and extrapulmonary TB. We didn't consider drug resistance. We didn't consider HIV. That could be impact for some other countries, not for these CR regional countries, but for if we want to do this similar kind of analysis for some where HIV is much higher, we should consider HIV, of course. But here we didn't consider. And subnational variation of nutrition status is not considered. In Rebecca's talk, someone was asking about subnational variation. We didn't consider. There is no data as of now for doing those kind of analysis. And we need more evidence for wider range of geographics, like we consider only for Jharkhand, only one small state where BMI in the low BMI setting mainly. So we should consider, we should get analysis, and we should go similar kind of result from in different parts across the country. That would help us for constructing this kind of analysis further. And again, another thing is important limitation is that the information we got from the recent trial is only for the household context, but we are applying those information, the same information, to the general population. Means in the low BMI population, we are giving support and we are looking at the impact from them. So actually, we need potential study, means like vaccine trial. We need some similar kind of information for nutritional status to apply the model to get the impact. So in summary, we can say that nutritional intervention varies from country to country. It's not fixed. It varies as low as 5% for Bhutan, whereas we got the impact in India 16% on incidence. Similarly, for cumulative mortality, you got 12% for Bhutan, and whereas for India it was 26% by providing 30% of people in low BMI per year. But if we target only household contacts, obviously the impact would be much lower. In India, about 5%, whereas Bhutan less than 1%. And overall, we can say that nutritional support could have impact on TB epidemic for this region, but this would not be sufficient to reach the NTB goal, that is 90% or 95% incidence and mortality reduction respectively in 2035 relative to 15. That is not possible by alone nutritional intervention. So that's all, I think. I would like to thank, these are my collaborators, Binit Bhatia from WHO CRO office and Anurag Agarwal, that person, and this means Suman Rijay and Nimal Nanavabhethi for their contribution in this work. Thank you for your patience.
Thank you, Sandeep. Any questions from the audience?
Yeah, please.
Sandeep, just a quick question for you. Like, what do you think is the prospect for extending your model to subnational geographies?
Of course, it would be interesting because in subnational geography means in India, the variation is so high. Means India, India is a big country with the different states have different characteristics. So if we have sufficient data, means that kind of study is required. That is also means one limitation of this study, of this work. Of course, if we we can do this.
Great.
The data is the only limitation.
Okay, we have one question from the audience here.
Hi, Sandeep. This is Puneet. Thanks very much for the presentation and really amazing work. And thanks for addressing the issue of scale and the difference between feeding larger parts of the population versus limiting it to that subset of contexts and elevating the importance of, especially in Southeast Asia, of extending it among contexts of privately notified patients, which is often usually overlooked in the implementation of such activities. My question had to do with the way you applied the risk reduction of the ration study to the low BMI population in the development of the model. My understanding was that risk reduction is amongst the incidence of disease amongst the overall population of contexts, sort of irrespective of their BMI. And it seemed to be that you were applying that risk reduction amongst those contacts who had low BMI, like it was limited to, I guess what I'm trying to get at is that, perhaps I misunderstood, but what I'm trying to get at is that my understanding from rations is that there might have been a differential risk reduction hinted at amongst that, in terms of that the reduction in incident disease wasn't necessarily associated so cleanly with those contacts who had low BMI, but actually seemed to actually trend towards those who didn't have low BMI. And how did you, I guess, translate that sort of odd and difficult to understand finding to the way you structured the risk reduction among contacts in your intervention? Thanks.
Thank you, Puneet. It is a really interesting question, and it is not clearly mentioned how it is modeled. The household contact is modeled through this. So yes, the impact would be not only on the low risk group, but those who are in the low, not only in the low BMI population, but also with the general population, as we observed from recent trial. So we modeled it separately, means we indirectly estimate what could be the impact if we target household contacts. We estimate the number of household contacts. Then what could be the, from those numbers, what could be the impact of, what could be the reduction of incidence if we target household contact? Then what could be, if 40% reduction among them, if it get reduced. Now that is factored in the model to find what K value will give me that impact. That reduction in the K factor, what is modeled there, that way it is indirectly modeled. I don't know whether it is clear to you. So K means the rate of progression and activation rate. What K factor will give me that impact, that way it is modeled.
Great. Sandeep, I think there's more to dig into there. And I think there was one more question. Okay, I'm sorry, we have to cut it off. I'm sorry about that. But Sandeep, there's a lot of interest here. And so I think there will be other people contacting you just with follow-up questions. Thank you so much. Let's thank Sandeep one more time.
Yeah. Thank you. I'm happy to reach in the email also. You can share my email address. Yeah.
That brings our session to a close. Thank you so much for joining our Nutrition and TB session. And have a great rest of your day too.